Hello everyone, welcome to my channel. It's Keaton here with Nursing Ed KGS. So in today's lesson or video, we're going to be looking at a case study on atrial fibrillation. Now this is one of the most common types of cardiac arrhythmias encountered in clinical practice. And it's a condition where the heart's upper chambers, the atria, beat irregularly and often rapidly. And this leads to poor blood flow and increased risk for stroke, heart failure, and other heart-related complications. Now, the prevalence of atrial fibrillation significantly increases with age, affecting approximately 1% of individuals under 60 and up to 12% of patients between 75 and 84 years. Now, even if you're not working in an ER, there are patients who do develop new onset atrial fibrillation during the course of their inpatient hospitalization. Now, there are several risk factors that contribute to the development of atrial fibrillation, and this includes hypertension, heart disease, diabetes, thyroid disorders, sleep apnea. Understanding these risk factors is important for early detection, management, and also in improving patient outcomes. Join me. So we're going to explore a clinical study and we're going to look at the diagnostic criteria, some of the nursing interventions that are associated. And so the next time you encounter a patient with atrial fibrillation, I'm sure you'll be much more prepared. And if you're already familiar with caring for patients, then this is going to be a refresher. So let's get started. So Sheila is a 68-year-old female and she presents to the emergency department with complaints of palpitations, shortness of breath, chest discomfort, and lightheadedness that started suddenly last night. She reported feeling fatigued and anxious. Her past medical history include hypertension, type 2 diabetes, and she's currently on metformin and bisoprolol. She has no known allergies. So you will do her vitals, of course, and her blood pressure is 184/110. Her heart rate is 140, and it's irregular. Her respiratory rate is 20. She's afebrile at 36.6 and she is 94% on room air. Now, in a quick head-to-toe assessment, you notice that she's alert and oriented, moderately distressed just because of that irregular heartbeat and the uncomfortable feeling that is associated with atrial fibrillation. And other patients will report feeling anxious. As I said, she has an irregular rhythm. She has no heart murmurs, rubs, or gallops. On auscultation, she's clear bilaterally, no wheezes or crackles, and her abdomen is soft, non-tender, and there's no hepatosplenomegaly. Now, when you assess her extremity, she has no peripheral edema, and her peripheral pulses are palpable and symmetric. Some of the tests and investigations that you might anticipate the physician ordering for patients who do present like Sheila with new onset atrial fibrillation include an ECG. Now it can be a 12 lead or a 15 lead, and this is one of the primary tools that is used to diagnose atrial fibrillation. Now, the ECG will help to identify any underlying cardiac conditions as well as to rule out other types of arrhythmias that can mimic AFib, and they can also occur concurrently. Now, the physician is also going to order a chest x-ray, and it can be a chest x-ray in DI or it can be a portable chest x-ray. And a chest x-ray is routinely ordered just so that the doctor is able to evaluate the heart size and shape, and it can show other underlying conditions or disease processes such as an enlarged heart, which can contribute to atrial fibrillation. The doctor would also order a chest x-ray because it provides information about the size and condition of some of the blood vessels that are in the chest, which do influence your overall cardiovascular health. And a chest x-ray can also show or reveal other abnormalities such as a pleural effusion, lung masses, diaphragmatic issues, and other vascular processes. And together, they provide a comprehensive evaluation so that physicians and clinicians are able to make informed decisions about diagnosis, underlying causes, and appropriate management of atrial fibrillation. Now, in addition to these two tests, the physician will normally order some blood tests. For example, your electrolytes, because potassium, magnesium, calcium imbalances can either precipitate or exacerbate atrial fibrillation. And so we do want to know what your values are so that you can either be treated, as well as thyroid function test. Now, even though hyperthyroidism is relatively common and treatable, it can cause AFib. And so doctors would routinely check thyroid function tests, so including your thyroid stimulating hormones, your TSH, and your free thyroxine levels. The doctors will also order some kidney function tests. So this includes your creatinine and your blood urea nitrogen, and this helps to assess your overall renal health, as well as liver function tests, because the doctor is able to see your metabolism and also drug clearance, which will influence treatment strategies, because there are medications that, if it is that you do have liver issues, then it's going to be harder for you to clear certain medications out of your body. The doctor would also order a complete blood count, and these tests for anemia, infection, as well as other hematological conditions that might in fact impact AFib and management of AFib. Now, sometimes a C-reactive protein test is ordered just so that the doctor is able to assess if the patient has any infection or inflammatory conditions that can trigger AFib. And cardiac tests, including your troponin or your creatine kinase MB, might also be ordered because patients can have AFib as well as other cardiac issues, including maybe a myocardial infarction. And your glucose levels are going to be done. And in Sheila's case, she was diabetic, and so you do want to see how controlled their diabetes is, because uncontrolled diabetes does contribute to cardiovascular complications, including atrial fibrillation. Now, other tests that are ordered include your coagulation profile, and these will test your PT, which is not included here, your APT, your INR, so that you can evaluate the patient's blood clotting ability, which is going to be very important because for patients who do have AFib, one of the concern or complication is the risk for stroke. And finally, a lipid profile, which is also not on this slide. And the insight is that cholesterol and triglyceride levels can tell us a lot about cardiovascular risk factors. All right. Now, this is an example of atrial fibrillation on a rhythm strip. One of the first things that stands out to me is the variability or inconsistency in the R to R. And so if you were to take a piece of paper, even a ruler, to just measure the R to R, you would find much variability, and you'd realize that it varies without following any predictable pattern. Now, the R to R interval represents the time between heartbeats, and the longer the R to R interval is, the shorter the heartbeat, or lower the heartbeat, I'd say. For example, on a 6-second rhythm strip, an R to R interval longer than 1.2 seconds would correspond to a heart rate below 50, while an R to R interval shorter than 0.6 seconds would correspond to a heart rate above 100. Right? Now, the next thing that I also noticed on this rhythm strip is that there are no P waves. There are fibrillatory waves, but these are not P waves. Right? And so these are represented by here. Now, the absence of P waves represent the absence of atrial depolarization. And instead, what we have in atrial fibrillation is erratic fibrillatory waves. In atrial fibrillation as well, the ventricular rate can be slow, normal, or rapid. And it's often, especially with patients with new onset atrial fibrillation, it's often over 100 beats per minute. And if it's above 100 and the patient's symptomatic, oftentimes it will necessitate treatment. You'll also notice that you have irregular QRS complexes. The QRS complex, if you recall, corresponds with ventricular depolarization. And even though they might be normal in shape, they are occurring at irregular intervals. Now, in atrial fibrillation, the atrial rate can be above 350 beats per minute. So you're unable to count it. And then the ventricular rate can be between 100 to 180 beats. And as I said before, if it's above 100, then it's normally uncontrolled. While if you have a patient with atrial fibrillation and their heart rate is below 100, we normally say it's controlled. And so you have an irregular rhythm. P wave absent, instead you're seeing fibrillatory baseline. There's no PR interval because there are no P waves. And then the QRS complex will be between 0.06 and 0.10 seconds. So the results from Sheila's blood work are back. Now, her chest x-ray showed no acute cardiopulmonary abnormalities. Her cardiac enzymes were negative for acute coronary syndrome. And her basic metabolic profile showed that her random blood glucose was 10.9, and her thyroid function tests were unremarkable. Now, the elevated glucose level is a little bit significant because it indicates to us that Sheila's blood sugar or diabetes is not as controlled as it could be. And as I mentioned before, uncontrolled diabetes can contribute to the onset or exacerbation of atrial fibrillation because high blood sugar levels increase your risk for cardiovascular complications. And that's just something to think about, especially if Sheila does get discharged. You want to ensure that you're letting the patient know that they might want to follow up with their general practitioner or their family doctor or even their endocrinologist about other strategies to manage your diet and lower their blood sugar levels. Now, in the middle of everything, there are certain things that you will be doing as the nurse. So you'll want to insert 2 saline lock, place Sheila on continuous cardiac monitoring. You want to keep her NPO for possible cardioversion, review the current list of medication that she's currently taking, as well as when was the last time she had each of those medications. You're also going to assess for stroke and start to think about, and the physician will also think about systemic embolism prevention. You're going to manage her anxiety because palpitation does cause serious discomfort and anxiety for patients. You're also going to provide supplemental oxygen to maintain oxygen saturation above 94%. Now, there are sometimes when given like Sheila's age and other risk factors, then it alerts the clinician that they might want to start to think about anticoagulation. And sometimes these patients are started on maybe heparin infusion for intermediate anticoagulation, or they're given some other form of oral anticoagulation, such as warfarin or direct oral anticoagulation. And normally, if they are started in the ER or on the floor on the heparin drip, then the plan is that they are transitioned to oral anticoagulation. Now, when managing atrial fibrillation, clinicians often consider 2 main approaches: rate control and rhythm control. Now, in rate control, the focus is on controlling the heart rate in patients. Now, in atrial fibrillation, the atria beats rapidly and irregularly, leading to an irregular ventricular response. Rate control aims to slow down the ventricular response to a rate that is tolerable for the patient and prevent and manage symptoms such as palpitation, shortness of breath, and fatigue. Rate control strategies typically involve medication such as beta blockers, calcium channel blockers, or digoxin. And these medications slow the heart rate by blocking electrical signals that cause the ventricles to beat rapidly. Rate control is often preferred in patients with atrial fibrillations who have stable symptoms, significant comorbidities, or those who cannot tolerate rhythm control medications or procedures such as cardioversion. Now, rhythm control, on the other hand, focuses on restoring and maintaining normal sinus rhythm in patients with atrial fibrillation. And the goal is to eliminate the irregular heart rhythm and the associated symptoms. And this can be achieved through medications, so antiarrhythmic drugs, or procedures such as electrical cardioversion, catheter ablation, or even surgical MACE procedure. Rhythm control is preferred in patients who are very symptomatic or they're symptomatic despite adequate rate control, those with paradoxical or intermittent atrial fibrillation, those with a high symptom burden, or impaired quality of life due to arrhythmia. It's important to note that rhythm control strategies carry risk, as anything in medicine I'll say, including proarrhythmia. So it can worsen current arrhythmias. It can also cause new arrhythmias. And there are different medication side effects that are associated with some of these drugs, as well as procedural complications when you get to cardioversion. Now, the choice between rate control and rhythm control will of course depend on various factors, including the patient's symptoms, their underlying comorbidities, and in the end, there's normally an individualized risk assessment. So you're assessing the patient that will be receiving this treatment, as well as letting the patient know the risk that is associated with both, and allowing them to decide, do you want to start with rate control, or do you just want to go to rhythm control? And oftentimes in an emergency, that's a little bit different, but if the patient is able to communicate and understand what their treatment is going to be like, I think it's important that we communicate that as clinicians and as nurses. So we're going to look briefly at rate control. Now, the goal is to get the patient's heart rate less than 100 beats per minute, and also that a lot of these symptoms that are associated with atrial fibrillation, including the palpitation, the shortness of breath, the anxiety, the fatigue, are also go away. And this can be achieved by intravenous therapy or oral therapy. So we're going to look at 3 examples of rate control intravenous medications that can be used. The first is a beta blocker, metoprolol. Usual dose is 2.5 to 5 milligrams IV times 1, and it can be repeated for up to 2 doses if the patient's heart rate is above 120 beats per minute, or if their systolic blood pressure is above 100 mmHg. Now, beta blocker, or metoprolol specifically, reduces blood pressure and heart rate by blocking the effects of the hormone epinephrine on beta receptors. It specifically targets beta 1 receptors in the heart, which makes it very effective in lowering heart rate, reducing blood pressure, treating arrhythmias such as AFib, sometimes even managing angina, because it decreases the oxygen demand of the heart, and then it does improve the overall heart function by reducing the workload of the heart. The next medication is a calcium channel blocker, diltiazem. Now, diltiazem works by blocking the calcium channels in the heart and smooth muscles, and this leads to vasodilation. It also has a negative inotropic effect, so it reduces myocardial contractility, which helps in conditions such as angina and certain arrhythmias such as AFib. It also has negative chronotropic effect, so it slows the heart rate by inhibiting the calcium influx in the sinoatrial and atrioventricular loads, thereby reducing conduction velocity. And diltiazem is weight-based, so you would need to know the patient's weight, and it can be repeated if the patient's heart rate is above 120 or their systolic blood pressure is above 120. The next medication is digoxin, and the usual dose for digoxin is 0.5 milligrams IV, and digoxin belongs to a class of medications known as cardiac glycoside. And the primary effects of cardiac glycosides include increasing the force of cardiac muscle contraction, so positive inotropic effect, and slowing the heart down, negative chronotrophy. And it also acts on the cardiac conduction system, in particular the atrioventricular node. Digoxin in terms of it having a positive inotropic effect, it increases the strength of cardiac muscle contractions by increasing intracellular calcium levels. It has negative chronotropic effect, meaning that it can slow the heart rate down by enhancing vagal tone and reducing conduction through the atrioventricular node. And it can be repeated, but the repeat dose goes to 0.25 mg IV Q6 for up to 2 doses if the patient's heart rate remains above 120 after the initial dose. And just something important to note, if it is that you are administering these medications, if your institutional policy doesn't even say that you need to double check, I would. So once you've gotten that medication up, I would independently double check it with another nurse, just to be safe. Okay, so there are some times when patients do come in with new onset atrial fibrillation, and especially when their heart rate wasn't initially above 100 and the doctor will go to oral therapy instead. Now, some of the examples of oral medications that you'll often see patients receive while they're in the hospital for AFib, and they're also discharged on these medications to take either daily or BID. So metoprolol, bisoprolol, those are your beta blockers. Then you have digoxin, and then you have your diltiazem. And there are times even when you are given the intravenous medication and the doctor will let you know to give the first dose at the time of the IV medication if it is that their systolic blood pressure is above 100. And if not, they will let you know what time they would like you to give the oral medication. And just bear in mind that these medications, in addition to helping to control rate, they can also drop your blood pressure. So you want to know their blood pressure before administering any of these medications orally as well. Now, rhythm control, on the other hand, will involve your cardioversion orders. And patients who have especially new onset AFib, they are at risk for stroke. So you want to keep that on alert. And this is for all patients. Now, cardioversion can either be chemical or electrical. Chemical cardioversion involves the administration of antiarrhythmic medications to restore normal sinus rhythm in patients with atrial fibrillation as well as other arrhythmias. Now, these medications work by altering the electrical properties of the heart and suppressing abnormal electrical impulses that do cause arrhythmia. Chemical cardioversion is considered in patients who are hemodynamically stable with the recent onset of AFib, and particularly those patients without structural heart disease. However, the success rate of chemical cardioversion varies depending on factors such as the duration of the arrhythmia, the presence of structural heart disease, and individual patient characteristics. We're also going to look briefly at chemical cardioversion, and this is a procedure that is performed to restore normal sinus rhythm in patients with atrial fibrillation by delivering a synchronized electrical shock to the heart, and this shock temporarily interrupts abnormal electrical activity in the artery, allowing the heart's natural pacemaker to re-establish a normal sinus rhythm. Sedation or anesthesia is often administered to patients to provide comfort during the procedure. Electrodes or pads or paddles are placed on the patient's chest to deliver the electrical shock. The energy level of the shock is carefully adjusted based on factors such as the patient's body size, the duration of their arrhythmia, if they've had previous cardioversion done. Electrical cardioversion is highly successful for the most part in restoring normal sinus rhythm, with success rates exceeding 90% in appropriately selected patients. It's often preferred in cases of persistent atrial fibrillation, patients who are hemodynamically unstable, or those who have failed chemical cardioversion. Now, patients who are going to be receiving rhythm control or cardioversion, they will normally be on a cardiac monitor. And during the process, especially when you're giving chemical cardioversion, you'll want to keep your eyes on those monitors because these medications can cause patients to develop new arrhythmias, as well as you want to keep your eye on the monitor to know when the conversion happens. So you'll be looking out for what is called a cardioversion pause. Now, one of the medications that is commonly used for chemical cardioversion is procainamide. It's normally a gram in 250 normal saline, administered over 60 minutes. You're going to monitor for blood pressure and notify the physician if it is that their systolic blood pressure is less than 100 mmHg. And there are physicians who are proactive and they'll order a bolus to be administered concurrently or before the patient receives the procainamide. You're also going to monitor for prolonged QTC and notify the physician if their QTC goes above 460 m/s. You're going to monitor the patient's QRX and hold the infusion and notify the doctor if QRX weight increases by greater than 50%. Stop the infusion immediately if any new arrhythmias develop. So if the patient become bradycardic, if the patients develop any other type of arrhythmia, stop it. Now, if the patient does develop a normal sinus rhythm, you're also going to stop it, right? The next medication is propafenone, and this medication is contraindicated in patients who do have structural heart disease, reduced ejection fraction, significant sinus bradycardia, if they have cardiac system issues, or even if they have coronary artery disease. Now, propafenone is administered along with a rate controlling drug. So it's a combination cardioversion. Now, in step 1, you're going to administer the rate controlling medication, or just make sure that it's administered at least 30 minutes before the propafenone. So it can either be metoprolol or diltiazem in oral form. And then the propafenone usual dose is 600 milligram if your weight is above 70, and then 450 milligrams if you weigh less than 70 kilograms. And you're going to monitor the patient for up to 4 to 6 hours after the dose. So we're going to look after this slide at the medications that you will need to prepare so that the physician will have them available. And all these medications will be administered by the physician and titrated as well by the physician. You're going to place the pads on the anterior and posterior chest, ensuring that the pads are placed at least 10 centimeter away from a pacemaker or an ICD if the patient has any of these. You will draw your medications up for the procedural sedation, and as I said, the physician will be the one to administer it. You're going to ensure that airway management equipment and maybe your RT is present and available. You're going to set the defibrillator to sync mode and ensuring that you're resyncing the defibrillator and ensuring that it is in sync mode between shocks. And the initial energy would be set to 150 joules, or the doctor will let you know how much they'd like it to be set to. Normally, if electrical cardioversion is unsuccessful, or even before, the physician will consult with the internist on call or the cardiologist for other management. Now, some of the medications are frequently prepared for procedural sedation include fentanyl in micrograms, propofol in milligrams, ketamine also in milligrams, midazolam in milligrams, and naloxone IV. You want to have that on hand just in case. Thank you for sticking to the end if you did on this nursing case study. I hope it provided maybe new information, maybe it reinforced information that you already knew. If you did find this video helpful at all, please remember to like, share, subscribe, share it with a friend. Thank you.